we're going to go ahead and get started with our medical scholar seminars for today. As many of you who are watching either in the Zoom or on YouTube know, our medical scholar seminar series was named in honor of Timothy A. Johnson. He was the first dean of research here at VTCSOM and really believed strongly in the importance of merging both being a physician and doing science. And so typically we have people visiting from outside of our own institution, but today we're very privileged to have with us one of our own, Dr. Sandeep Mittal. He's going to be presenting the Medical Scholar Seminar Series today remotely as we are all sitting in our homes doing our sheltering in place. Dr. Mittal is professor and chief of neurosurgery at Virginia Tech Carilion School of Medicine and Carilion Clinic. Before he joined us at Virginia Tech, he was professor and chair of the Department of Neurosurgery at Wayne State University. He received his MD and Master of Surgery degree from McGill, and then he went on to complete his neurosurgery residency training and a postdoc in developmental neurobiology at McGill University. After that, he completed 2 clinical fellowships, one in epilepsy surgery and a second one in neuro-oncological surgery at Brigham and Women's Hospital. He's currently board certified by both the American Board of Neurological Surgeons and the Royal College of Surgeons of Canada. And his areas of clinical expertise are in the surgical management of patients with medically refractory epilepsy, as well as those with complex brain tumors located in eloquent brain regions. He also, in addition to this very busy clinical practice, is director of the Translational Neurosurgery Research Lab at FBRI. He's authored over 150 peer-reviewed manuscripts and book chapters and is a fellow of the Royal College of Surgeons of Canada and of the American College of Surgeons. We're going to hear from him today on a topic entitled Targeting the Kynurenine Pathway in Brain Tumors, Epilepsy, and Other Neurological Disorders. And then we invite you to stay on with us when he finishes to ask questions. So some of our students are logged in via Zoom. And if you are, please go ahead and type your question in the chat feature. And then I will go ahead and call on you and you can turn on your camera and ask Dr. Mittal your question. If you're joining us via the live stream on YouTube, please go ahead and use the chat function there. And I will be monitoring that and I can read those questions so that Dr. Mittal can answer them as well. So with that, I'm going to go ahead and let Dr. Mittal share his screen and take over and give us our seminar. Thank you.
Great. Thank you, Dr. LeConte. So I hope everyone can see the screen, can hear me, can see the pointer, and I'll get started. So today, I hope that we can, discuss and provide a broad overview of the Kynurenine pathway. And this is a very interesting topic. And once we initially began, delving into this area about 10, 15 years ago, it's has been quite a fascinating journey. So I wanted to share some of the experiences that we've had over the last 15 years and see where things can hopefully evolve over the next decade in terms of really having clinical translation as the next step. So we'll focus on brain tumors, but there's a historical component of it that starts in other neurological disorders, including epilepsy and even psychiatric diseases. Okay. The work that I'll be presenting today was funded by our R01, and I'll be talking about several patient, clinical studies, as well as a few of the preclinical studies, and of course had institutional approval for that, no other conflicts. So the main goals of the research lab are to develop biomarkers. It's a bit of a cliche now that targeted therapies and personalized medicine and so on, but what does that mean in real life? So you can only achieve these goals if you have appropriate markers, either that are unique to the individual or more commonly to the pathological entity. In this case, a tumor, for example. So developing And identifying those biomarkers, especially in neuro-oncology and neurological disorders, is not trivial, and we still are lagging behind other fields in that respect. Ultimately, we want to develop better tools to facilitate and improve our diagnostic, um, you know, armamentarium that we have. And of course, from the neurosurgical side, anything that can help us plan for intervention preemptively would be quite a valuable addition. Once we typically finish with our surgical intervention, patients will have other adjunct treatments, whether it's radiation therapy, chemotherapy, or combination of those. But those treatment modalities in themselves can have deleterious effects. So assessing the response as well as side effects or ulterior complications from those treatments can also be quite valuable. So we try to achieve these goals using two broad research methodologies. Of course, having easy and ready access to patient material. So most of the studies and experiments that we do involve patient-derived specimens. And we've adopted this molecular imaging-based approach using amino acid PET tracers as our mainstay in terms of trying to achieve the above mentioned goals. And just to give you a prelude of what's to come, so this is a combination of standard diagnostic MRI scans together with the corresponding PET imaging modalities. So you can see that both enhancing, where there's uptake of contrast, and non-enhancing lesions can have significant hypermetabolism or increased uptake of the radiotracer. And depending on the lesion and depending on its inherent characteristics, the uptake parameters will be quite different. And of course, the patient material. So, whenever a specimen is removed from the operating room, of course, the first and most important portion that goes is to the clinical pathology lab, so that the neuropathologist can do their clinical diagnostic workup and analysis. But generally speaking, there's a lot of tissue that's left over, and that's not generally discarded. And instead of wasting that tissue or having it in storage forever, that what we've tried to do is to maximize uh, the, um, the benefit from that. So a significant portion of the resected specimen we will collect and bring to the lab, and a portion of that research tissue will be flash frozen so that we can extract nucleic acid. We'll fix tissues for subsequent immunostaining, dissociate into single cell suspensions for the in vitro work, and of course, either with cell suspensions or sometimes chunks of small fragments of tissue that can be implanted into our preclinical animal models to generate our patient-derived xenografts. So now a bit more about amino acid PET imaging. So beyond CAT scan and really MRI as the gold standard for diagnostic imaging of brain structures, an amino acid-based molecular imaging approach is quite valuable as well. We know that glucose-based or FDG PET scans that are the mainstay for most malignancies. So that's probably the most common use for FDG PET would be for workup of a patient with an extracranial type of malignancy, lung cancer, breast cancer, and so on. For it can all cells require glucose for metabolism, and the more aggressive the underlying cell in terms of growth and invasiveness and so on, the higher the uptake as a reflection of metabolism. So amino acid PET has significant advantages specifically in the brain because as you can imagine, the brain, both neuronal and non-neuronal populations are highly metabolically active. So the background of uptake on standard FDG PET images is quite high. and the difference between normal tissue and our lesion or area of interest can be suboptimal. So amino acid tracers have a significant advantage over glucose-based tracers. And we know that tumor cells can take up amino acids in large quantities, um, and often larger quantities than the normal surrounding brain structures and cells. And there seems to be a significantly higher sensitivity to detect viable tumor tissue by PET imaging using these radiolabeled amino acids as opposed to other types of tracers. We know that once the radiotracer is injected intravenously, that it circulates in the bloodstream, and depending on the specific tracer, it can have unique fates in terms of how, whether it's metabolized, whether it's incorporated into proteins, and the protein synthesis machinery, and that can be exploited, and we can get the pros and cons of each tracer based on its unique properties. So they can, as I mentioned, they can get trapped within the cell body without any changes, structurally speaking. They can get, in part at least, incorporated into proteins, or can also get metabolized through various pathways that are unique to the individual amino acid. And just a very quick overview of the different types of amino acid radiotracers. Methionine is probably the most common amino acid tracer used in North America. It's a C11 based, and C11 has the unfortunate property of having a very short half-life, about 20 minutes. So you really need an on-site cyclotron in order to synthesize the compound so that you can very quickly inject and get your imaging studies completed before a degradation of the underlying radioactive properties. But methionine provides improved delineation of tumors compared to other imaging modalities and can be a good adjunct to your MRI images. And of course, as is the case with most amino acid tracers, both slow growing and more aggressive lesions can have increased uptake. Fluoroethyl tyrosine, or FET PET imaging, is probably the most common modality used in Europe, and there have been hundreds and probably at this stage a few thousand patients that have been scanned using FET based PET imaging. And one of the main advantages of the FET tracer is that it's an F18 compound. And F18, just like fluorodeoxyglucose, or FDG, scans, the half-life is about 110 minutes, so that it can be synthesized off-site. It can we can produce it in larger quantities and ship it overnight. And given the residual activity, it can be used by centers that are at several hours distance, so that it becomes a much more clinically meaningful isotope for clinical use. F-DOPA, so dopamine, or its a precursor phenylalanine based imaging, is less common, but as you can see from the imaging, can provide very distinct margins of uptake. Of course, as you can imagine, with any dopamine based imaging modality, it's going to have higher uptake rather than the cortical surface. It's going to be your deep ganglionic structures that may have contamination based on background uptake. And just like FET, PET, F-DOPA PET, also F18 based with the longer half-life. So, with this background, very early on, we chose to do most of our investigations using a tryptophan-based radiotracer. And this slide will just provide a quick review of tryptophan. So as you may remember, that tryptophan is one of the essential amino acids. It's actually the least abundant of the essential amino acid, which means that everything that's in the body has to be ingested. And this is just a simple photograph of the foods that are rich in tryptophan content. So, as an essential amino acid, it's a building block for protein synthesis. And in fact, a very small, and it's probably less than 1% of ingested tryptophan is actually incorporated into proteins. Whereas the vast majority, 95, 98, 99% of circulating tryptophan is actually metabolized through different pathways. And depending on the organ or the cell type, it can be preferentially um, transformed into tryptamine. So, for example, in the dorsal raffinucleus, through the serotonergic pathway, can metabolize into serotonin, and of course is also a precursor to melatonin in the pineal gland. For our purpose, we're really focused on the kynurenine pathway, and that's really out of all of these different fates, the kynurenine pathway represents the vast majority of the path where tryptophan is metabolized. And this is a simplified, without all the details and all the different steps, but and I'll try to go through this in a rational manner so that it's not doesn't get too overwhelmed. So you have circulating tryptophan. This represents the cell body. So this is in the interstitium. We've already talked about protein synthesis, that small subset that will go into this path. Serotonin, melatonin will be in select regions of the brain. But through specific amino acid transporters, and in our case, the LAT1 transporter, tryptophan gets uptaken into the intracellular compartment where it's rapidly metabolized through the first and rate-limiting enzymes. So IDO, or indolamine 2,3-dioxygenase, and there's two isomers, so IDO1, IDO2, and its sister enzyme TDO are the initial and rate-limiting enzymes, and through a series of intermediary metabolites ultimately give rise to kynurenine. So essentially, tryptophan transforms into kynurenine through these three important enzymes, and these we'll come back to later on. And kynurenine, through another series of transformations, will form to become kynurenic acid. And again, this will become relevant, especially in neurological conditions. And then in the downstream portions of the pathway, ultimately the main purpose, the physiologic purpose of kynurenine pathway is the synthesis of NAD. And we know that NAD is a critical coenzyme that's responsible for most metabolic activities in all living cells, in fact. And getting back to the two main metabolites, so kynurenic acid, as it turns out, is an NMDA receptor antagonist, so that it has the net effect of regulating or decreasing the excitation within the nervous system, and is thought to be neuroprotective in nature. Whereas quinolinic acid, in contrast, is an NMDA receptor agonist. It actually is there's a high stressor in terms of oxidation and so on, and overall is thought to be neurotoxic. So when we talk about, let's say, neurodegenerative disorders like Huntington's, Parkinson's, Alzheimer's, there's going to be an imbalance between low levels of kynurenic acid and much more increased supraphysiologic levels of quinolinic acid and other metabolites within the pathway. So again, getting back to the tryptophan in terms of what are the main physiologic goals of tryptophan that we ingest. Well, as we just saw, it's the precursor for all or most of the NAD biosynthesis that occurs in all living cells. The pathway itself generates a range of metabolites that are collectively known as kynurenines as a group. So, and these kynurenines are involved in a very wide range of physiological as well as, unfortunately, pathological conditions that are really seen throughout life, from infancy to death and everything in between. And as you dig deeper into the pathway and the topic, you'll find that it has a central critical role in inflammation, including neuroinflammation. It has a very important role in the immune response. I brought up neurodegenerative disorders, but also neuropsychiatric conditions, normal aging process, diabetes, malignancies, every single organ you can think of, and really, as you start looking and exploring the topic further, you'll notice that there are several groups that are working on almost every single aspect of human diseases, and somehow the Kynurenine pathway appears to play a critical role in that. In fact, several years ago, as we got into the collaborative phase of the work, it turns out that there is a tryptophan society. It's called the International Society of Tryptophan Research, and about 200 of us get together every couple of years to discuss the Kynurenine pathway and everything related to tryptophan. It's kind of interesting, but very unusual type of meeting. In any case, in the brain, these metabolites of the kynurenine pathway, or kynurenins, can either be neuroprotective or neurotoxic, as we saw. So that's the background on tryptophan. Now, how do we take those properties and that background and come back to our molecular imaging modalities? So how do we take this molecule, stick an isotope so that it becomes a radiotracer? And there's different version of it. And in the late 1980s, in Montreal, at the Montreal Neurological Institute, where I did most of my training, there was development of alpha-methyl L-tryptophan. So the addition of this methyl group in this location was used. Originally, the idea was to study a more psychiatric disorders like depression, schizophrenia, and so on. Remember, tryptophan is the precursor for serotonin. So that was the initial angle that Dr. Dixit was interested in. And one of the key properties of AMT is that it's not incorporated into proteins, so that whatever we see in terms of uptake on our PET images is really the portion of the molecule that is either trapped within the cytosol or is metabolized through the different pathways, and as we saw, primarily through the kynurenine pathway. In terms of the initial experience, as I mentioned, was related to neuropsychiatric conditions, so more serotonergic based, as well as normal healthy controls. And this, for many years, the group at McGill and Montreal was focused on that. And then about 20 years ago, in Detroit, we got interested in expanding the indications for AMT for other neurological disorders and conditions. Initially, as we'll see in the subsequent slides, really the interest peaked with tuberous sclerosis. And as hopefully you'll appreciate that over the last decade or so, our interest has evolved to a wider range of neurological conditions, including CNS tumors. So just a bit of background on tuberous sclerosis. It's a genetic disorder that, in addition to the cranial pathology, actually affects the eyes and a whole host of other extracranial organs. It results in developmental delay, intellectual cognitive disabilities, and prominent seizures in the kids that have TS, tuberous sclerosis. Very standard, typical, prototypic neuroimaging findings, these calcified subependymal nodules. When one of these nodules is located at the foramen Monroe, it has a tendency to form an astrocytoma that we term specific histologic type of lesion that's called the SEGA, or subependymal giant astrocytoma. And of course, for our purpose, we're interested in the cortical tubers. These patients have a lot of intractable, often seizures, And this is thought to be due to the hematomatous or the dysplastic nature of these cortical tubers. And as you can see in this patient, it's like dozens of lesions, and often it's not uncommon that an individual will have not just several in the teens, but can have several dozens. We've encountered patients that have had over 100 of these cortical tubers. And interestingly, that we know from EEG, so electrographic data, that are either groups or a dominant cortical tuber that will often be the source of the seizures. And we would term that as the epileptogenic cortical tuber. And of course, based on the imaging, it's impossible to determine, is it this guy that's causing the seizures or this one or that one and so on. So the EEG may help guide in terms of regional localization, but again, EEG doesn't have the spatial resolution to differentiate whether it's, again, in a hypothetical scenario where if the seizures are coming from this one or that one. We know from histopathological studies that resected epileptogenic cortical tubers had high levels of the kynurenins, or the kynurenine pathway metabolites. So then, during this time, again, it's the early 90s now, as there's more exposure to the EMT PET tracer, and this in parallel to this finding of quinolinic acid and other downstream metabolites within the resected specimens, that's when they began to investigate these tuberous sclerosis patients with AMT PET images. And you can imagine that these are not aggressive malignant lesions. They're non-neoplastic lesions, dysplastic, hematomatous, so that on glucose or FDG PET, they'll be, as expected, hypometabolic. So you can see the normal high glucose uptake on the cortical surface, as I mentioned earlier, so the high background noise, and the area of abnormality or pathology is actually low uptake of glucose or hypometabolism. And again, FDG is of no use in differentiating the non-epileptogenic cortical tubers from the epileptogenic one. AMT, at that time, surprisingly, we can see that in spite of having the dozens of cortical tubers, there was in this example, a single dominant tuber that had high uptake. Now, why is that? What's so special about this tuber that is unique in terms of its underlying characteristics and properties that AMT, the tryptophan molecule, is not getting into the other cells of the other tubers? As they looked at resected specimens of AMT positive uptake areas, and correlated with EEG findings, not surprisingly, there was a direct correlation between electrographic abnormalities and high uptake of AMT. And again, presence of the quinolinic acid and other kynurenins within the resected specimen. And again, this goes back to the neurotoxic nature of these kynurenins, often, especially the downstream ones. So this is at this point where, so actually in my training in the mid and late 90s, this was the only use of AMT PET imaging, was for the unique tuberous sclerosis patients that we wanted to supplement the EEG findings and determine which cortical tuber to resect, essentially, as part of the preoperative epilepsy surgery workup. So during most of the 1990s, and early 2000s, that was the only real indication for clinical indication for AMT PET. Then we started getting into expanding our net in terms of, well, what other patients can potentially benefit. If epileptogenic cortical tubers have the neurotoxic metabolites within the cells and the region, as well as in parallel increased AMT uptake, what about other non-tumoral but yet epileptogenic lesions? Would they share similar properties? So what are examples of those non-tuberous sclerosis pro-epileptic pathologies? Well, cortical dysplasia is one example of a family of malformations of cortical development that occur and that are epileptogenic in nature. There are a whole slew of neocortical epilepsies that also can be lesional or non-lesional, that can result in epilepsy. And interestingly, in these uh, additional neurological conditions leading to epilepsy, we also saw a significant increase in accumulation of the AMT, of tryptophan. And in this example of very focal uptake corresponding to the area of EEG onset of seizures, and you can see that on the FDG PET study, there's the expected decreased metabolism. So something is unique to this epileptic tissue that's promoting uptake of tryptophan, and so that in the intuitively upregulation of the kynurenine pathway. So then, as we expanded our indications and broadened our use of the tryptophan tracer, we came across this individual, and this was a very unique case that we actually wrote up, and it was quite informative. So this patient was actually, young guy, relatively young guy, that was playing golf with his son on a weekend. It was on a Saturday, and he, for no apparent reason, started having seizures. Initially focal seizures, and then subsequently intractable, non-responsive seizures. Was admitted to a peripheral hospital, transferred to our center for more invasive workup and definitive management of his refractory seizures related to new onset of status. In fact, that he had continuous uninterrupted electrographic and clinical seizures. And on his initial imaging was found to have this discrete non-enhancing lesion. So if I look at it today, just as I looked at it 10 years ago, this is consistent with a low-grade glioma. With, as you'll see, and often about 90% of patients with low-grade gliomas will present with seizures. So this is a classic story, and minus this is a pretty egregious and severe form, getting into status that's relatively rare, but a low-grade glioma presenting with seizures is the common scenario. So that when we did our initial preoperative workup using the tryptophan PET study, we were surprised that not only was there increased uptake in the lesion, but also in far away regions, adjacent and quite distant regions from the MRI abnormality, as you can see on this axial image and this 3D recon. Based on EEG and MRI, we actually ended up performing a large resection. He thankfully remained seizure-free after the intervention. And what's interesting is that at that time, we actually, because of there was a sulcus here, and there was no electrographic activity beyond that posterior temporal occipital region, so we elected not to resect to that area in spite of having increased AMT uptake. Okay? And what we saw on the follow-up scan is that there was normalization of the increased tryptophan metabolism following resection of the epileptogenic tissue. So that's very interesting finding. Histologically, to our surprise, the neuropathology said, well, no, this is not a low-grade glioma, but it's actually a neuroinflammatory type of tissue, non-descript, but as you can see on this GFAP stain, significant astrogliosis that's present. When we looked more carefully, we saw that there was in the AMT positive uptake areas, which are the lower two panels here on the left, we saw there was increased co-expression of IDO. Remember the one of the initial and rate-limiting enzymes from tryptophan to kynurenine, together with co-localization with IL-1 beta in terms of, again, indicative of the neuroinflammatory type of mass. Corresponding to the cytokine, there was also increased expression of IL-1 receptor in the tissue that had increased AMT uptake, as well as EEG abnormality in terms of seizure onset. In contrast, adjacent areas that had low uptake of AMT and that were not active on EEG had low expression of IDO, IL-1 beta, and IL-1 receptor. So again, the story of tryptophan metabolism, kynurenine pathway involving epileptogenic tissue becomes more and more, interesting. So, so up until this point, we're still in the phase of non-neoplastic lesions, non-neoplastic epileptogenic lesions. And then those of you who are familiar with DNETs or disemeroplastic neuroepithelial tumors, these are, very, very indolent, very slow-growing, glioneuronal tumors that have both glial and neuronal elements or cells within them. And almost invariably, 95, almost I would say 100% of patients will have seizures, and a good chunk of them will be refractory. So initially, we started off, with the standard epilepsy workup by using, diagnostic standard MRI with epilepsy protocol or FDG to localize the area of hypometabolism. And then in select cases where we had surgical failures, so the tumor is gone, but they're still seizing. In those subset, we started saying, hey, it would be interesting to see what the AMT uptake is like. And to our surprise, the AMT uptake, again, this is probably one of the slowest growing, most indolent type of tumors, but you can see that this is behaving as if it's, it's like lighting up, like a light bulb, literally, in terms of its high accumulation and uptake. And when we looked at a series of DNETs, we saw that in fact, in spite of its low underlying activity in terms of metabolism, preferentially there is increased metabolism of tryptophan, and again through our histologic studies demonstrated that the enzymes and metabolites of the kynurenine pathway are preferentially have increased expression. You may recall earlier I mentioned that there's a specific transporter, transmembrane transport protein, the LAT1, that is primarily responsible for transporting tryptophan and other large amino acids into the cells. And again, it's the LAT1 is interestingly highly expressed in capillaries in the brain, and you can without getting into dwelling into the blood-brain barrier and so on, but it has a critical role in that endothelial cell function. So you can see that in DNETs there is increased expression of these various enzymes and metabolites and transporters of that are relevant to the kynurenine pathway. So then at this stage, we asked ourselves, well, is there a broader role of the kynurenine pathway in CNS tumors? And up until that point, this question remained unanswered. And this is just a cartoon to kind of hopefully better describe what happens. So tryptophan is ingested, it gets into the brain, it gets converted into kynurenins through the initial and rate-limiting enzymes, the IDO, the two isomers, and TDO. And then you have increased concentration of kynurenine within the cytoplasm. Kynurenine, as it turns out, is an endogenous ligand for AHR, or the aryl hydrocarbon receptor. And as kynurenine binds to AHR, it actually is translocated into the nucleus, where it binds to the dioxin response elements and ultimately results in increased expression of targeted genes. Interestingly, IDO1 and 2 are also part of those genes that are increased in terms of expression, and then this forms a bit of a autocrine loop, feedback loop, so that the more the kynurenine pathway is upregulated, the more expression of IDO and TDO, the more levels of kynurenine, the greater the ultimate expression of IDO, and so on. Beyond, beyond the tumor cells, that in addition to IDO1 and 2 and TDO, it also results, this pathway also results in upregulation of expression of proliferation and migration genes. In contrast, when you have either circulating immune cells, lymphocytes in this case, that you know as as one of the downstream effects of this binding nuclear activity of AHR is increased expression of FOXP3, and this we know is detrimental in terms um, of the immune surveillance that normally occurs in normal conditions, including the immune surveillance of tumor cells. So there's essentially a transformation of active lymphocytes into T regulatory cells and so on. So on one side, you have um, a constitutive expression of these enzymes and metabolites in many cancer types that result in an overall immune suppressed condition and environment. And it had been shown for non-cranial lesions that this represented a poor prognostic factor. So how do we then integrate our imaging modality that we believe is an effective surrogate for tryptophan metabolism? It's a non-invasive way to determine whether the pathway, the kynurenine pathway, is upregulated or not. So what are some of the main clinical questions that we ask in our neuro-oncology tumor boards? Well, is there an easy way beyond MRIs, which has its own limitations, and in spite of advanced MRI techniques like perfusion studies and DTI and spectroscopy and so on? So all these things are helpful adjuncts, but they're not definitive. So MRI definitely has limitations. You know, so is there a way to augment our pre-intervention type of diagnosis? So can you differentiate amongst the different types of CNS tumors? The grading or the aggressiveness of these tumors, is there a way to differentiate based on their PET imaging characteristics? What about the proliferation and the rate of growth and predictability of growth? Is it going to be more indolent or more aggressive in terms of its underlying growth parameters? I mentioned earlier that radiation, chemotherapy can have radiological consequences, and often, especially for high-grade gliomas, for example, glioblastoma and so on, it's very difficult to differentiate whether an area of enhancement is going to be corresponding to tumor recurrence versus necrosis or treatment-related effects. So that, back in the day, one of the main reasons to do a biopsy or reoperation in those patients was to actually answer this question. The only way at the time was to determine, to answer the question of whether it's active tumor versus necrotic tissue, was to actually get a piece of the tissue and send it to the neuropathology department to get, to answer this question. So one of the main early questions that we posed ourselves was whether this modality using tryptophan PET would facilitate some of these questions. But then, of course, we all, any type of good imaging modality should be, or at least we hope, would be helpful in terms of monitoring the positive or absent treatment effects. Can it be useful as a prognostic indicator? So can this be an imaging biomarker, essentially? And then, of course, at this point, we suspect, but we don't know definitively whether AMT PET correlates with the kynurenine pathway itself and the underlying immunosuppression that's seen in cases where this pathway is overexpressed. So in terms of glioma type, if I look at this MRI, non-enhancing discrete lesion in the non-dominant right temporal lobe, it's impossible for me to know which of the dozen or so low-grade glioma this is going to be. And that was the case 20 years ago, and that's still the case today, more or less. And here comes our AMT PET studies. And after scanning a large number of these cases, and without getting into details with it's a complicated kinetic analysis that's done. So the physicist uses these three compartment models and PET-LAC curves and so on, and through complex calculations and so on, we can have quantitation of uptake, of volume of distribution, a slope, and so on. And each parameter corresponds to different, different clinical parameters. So is there increased uptake of tryptophan? Is there increased transport? Is there increased metabolism, and so on? So each of these ratios or parameters within the quantitative kinetic analysis of the the PET studies provides that information. And what we found is that when we looked at this, and again, this K3 prime tumor to cortex ratio was was the defining factor that could segregate based on histology. So that we mentioned DNETs earlier. So DNETs have a very specific lower ratio compared to oligodendrogliomas, compared to astrocytomas or mixed oligoastrocytomas. And it's a very, very powerful, tool that, I don't believe that there's any other imaging modality that can segregate amongst the low-grade gliomas like this. So it becomes quite interesting in terms of preoperative, pre-histologic assessment, and you have a high probability of knowing which histologic tumor type it's going to be. What about proliferation? Sometimes we get a surprise. You often correlate presence of enhancement with aggressiveness, that if this is a non-enhancing, so it must be low grade. But it's not infrequent that there may be anaplastic or high-grade features within this. And sometimes, especially back in the day, where a lot of treating physicians would watch and wait and not surgically resect these slow-growing lesions, often there would be a surprise several months or a few years prematurely down the road. So one of the main clinical questions and that can guide management is, do we have a non-invasive preoperative way of knowing and predicting what the proliferation or the aggressiveness would be? And the answer is yes. And we can see that as we correlated Ki67 labeling within various gliomas in terms of across ranges of low grade, grade 3 anaplastic, grade 4 and glioblastoma, we saw a nice correlation of increased, again, without getting into the details, but increased quantitative parameters based on uptake corresponding to the proliferation index. Coming back to is it tumor or necrosis? And this is one example where you have a patient that's had surgery, that's had radiation, chemotherapy, and again, this is a glioblastoma patient, and on follow-up MRI, there's this very ill-defined, I don't know if, I hope you can see these punctate dots of enhancement which weren't present on on previous scans. So what is this? Is this treatment related? Is it related to the radiation, the chemo? Is it surgical sequela? Or is it something that's more progressive and more worrisome? FDG PET in these scenarios, as is often the case, is useless. I mean, it shows an area of hypometabolism. And if you just stop there and you ignore the right column, you would say, well, let's watch and wait, repeat the scan in 3 months. And in 3 months, there may be a big surprise. And more often than not, perhaps a neurological decline before you reach your follow-up imaging time. And in these circumstances where we had clinical doubt in terms of clinical and radiographic uncertainty in terms of necrosis versus active tumor progression, when we scanned these individuals with the tryptophan tracer, we saw to our surprise that not only is there significant uptake in areas that are very benign on glucose imaging and underlying MRI, diagnostic MRI, but interestingly, for example, in this case, an unexpected area of increased uptake in the temporal region, and without any, and the deep insular area, and without any corresponding MRI abnormality. So in this case, as it turned out, and we did a whole series of cases where we had histologic confirmation of this, that the uptake, increased uptake of tryptophan within these post-treatment patients is correlates with recurrence, and you can actually use this as a basis of differentiation between treatment-related injury or necrosis versus recurrence. Um, at some point, we said, okay, well, this clearly is, this is like seems to be a very valuable adjunct to MRI and almost like the best thing since sliced bread. So what are other areas that are limitations on MRI? One of the things that we know is, and gliomas, infiltrating gliomas are the classic example of infiltrating type of lesions. So that what you see on the MRI is just the tip of the iceberg. We know that the contrast enhancement is, yes, we know that this is where the highest density of tumor cells are located, but we know that areas that are distant from this area also have infiltrating cells. And we know from old autopsy studies that even contralaterally there's a presence of infiltrating cells, albeit at a much lower density, but they're there. And this is the source of the tumor reservoir cells that form the basis of recurrence, and often these are the cells that are also resistant to radiation and chemotherapy. So on the post-contrast MRIs, often you'll be a discrete margin of the tumor, and beyond the margin, we know that there's infiltrating cells. We often will supplement the T1 post-gadolinium images with the T2 and FLAIR images, which will have, the problem with these hyperintense volumes is that it's a combination of tumor infiltration together with peritumoral edema, so that this hyperintense region may or may not correlate with, is this a better depiction of area of actual, tumor margin, or should we stick with the post-contrast? In this paper, we did, very meticulous sampling of, all different permutations of, AMT positive, GAD, T contrast positive, FLAIR positive, T1 contrast negative, FLAIR positive, AMT positive, and so on. So all the permutations that you can imagine, related to those three variables. So uptake of AMT, hyperintensity on T2 and FLAIR images, and presence or absence of contrast. And what we saw is that whereas the contrasted region underestimated, as expected, the area of highest density of tumor cells, and the hyperintense region overestimated, we felt that the tryptophan uptake region had the best correlation with tumor infiltration, so that it had the region that had the highest the region that had the highest uptake of AMT also corresponded with the area, histologically speaking, of highest density of tumor cell infiltration. So again, this becomes a very clinically meaningful and powerful tool. Now, of course, this is still in our clinical trial and experimental phase, and standard of care surgically. The clinical standard of care is for a gross total resection is to remove everything abnormal that we see on the MRI, i.e., the contrast enhancing area. So in the first phase of the cohort of these patients, I was only doing standard of care in terms of removing, the area of tumor. Now, all these glioblastoma patients, you have a tumor, you resect the tumor, and then you radiate, and then you follow up every 2-3 months with MRIs. And then not unexpectedly, but you see an area of increased uptake, and as we started getting better with our differentiation of necrosis versus actual tumor, we could see that there were very localized nodular areas of recurrence. It wasn't all around the periphery of the surgical cavity, but really located preferentially in one aspect, anterior, lateral, superior, and so on, as you can see in this image. So then, we got interested in saying, well, wait a minute, we know that we are not, if I go back to the surgical slide, the area of AMT uptake is much larger than our contrast enhancing. Standard of care, surgery-wise, is remove this and leave the delta, leave all of this behind, right? So then there's a whole cohort of these patients that have none of this volume, but residual AMT positive volume. What happens when you follow and repeat the scans, both MR and AMT on these patients? Can you predict where the tumor is going to recur or progress? And in fact, we can, as I alluded to in the previous slides, that the area of highest infiltration seems to correspond with the area of uptake. And if you leave that uptake behind after surgery, then that's where the highest residual reservoir of tumor cells remain, and that's where the tumor is going to recur. And that was also quite, quite a landmark, study for our group in terms of after this analysis, I began to, whenever it was appropriate, to actually expand the margin of resection to include as much as possible the AMT positive area in order to minimize and maximize extent of infiltrating microscopic tumor cells and ultimately reduce the risk of recurrence post-radiation chemotherapy. Ultimately, any type of imaging modality that you do, the goal, at the end of the day, we have to determine whether all of this is fine and dandy, but who cares, right? So it's good in our hands, but how can you extrapolate to other centers and to make it a widespread, type of use? So does it have any value in survival? And this again was a very very defining point in our journey, I guess, using this tracer and amino acid PET imaging as a whole. In neuro-oncology, unfortunately, we don't see Kaplan-Meier survival curves that are like this. Often there'll be significant overlap. At most, there'll be a few weeks, a few months, if we're lucky, of separation and an increased progression-free or overall survival. And and at this stage, and this is about about 7-8 years ago, and that up until that point, we divided our cohort of patients. At that point, we probably had scanned 300-400 patients, with various types of CNS tumors. And among GBM patients, we divided them into two subgroups: those that had low uptake within the tumor, and those that had high. So low is in blue, and high in red. And both the uptake and, again, the kinetic parameters, the complicated three-compartment analysis and so on, showed that a clear separation in terms of overall survival between those that had low uptake to those that had high uptake. Now understand that this is a preoperative single PET image that can predict whether, so if you look at the median survival, whether it's going to be 5 months or whether it's going to be about 2.5 years. And that's a very powerful tool. There's no other, biomarker or imaging modality that can tell you at a, presentation, pre-intervention, surgical or otherwise, what your overall prognosis is going to be. Very, very unique type of circumstance and situation. So this obviously got us much more interested in terms of, well, we can't, we have to find, do whatever's needed to extrapolate so that, 5, 10, 20 years down the road, that every center can benefit from, from this experience and from, can do these type of studies routinely for all patients. More recently, and this is, I think, a paper from last year, we looked at, glioblastomas specifically are very heterogeneous. So they're, the tumor in itself, has many subregions. It's not that it's all enhancing or all non-enhancing and so on. So then we carefully, volumetrically looked at all the different subregions, correlated with different parameters on MRI, both, the T1 contrast, the flare, the perfusion, spectroscopy, DTI data, and so on. So really a multimodal type of comparison. And we found that in the area that had increased uptake, similar to the previous slide, so to this slide, that it doesn't, you don't need to have overall increased uptake, in the entire volume of the mass. But if you just confine it to the area that has increased uptake in that subregion, again, there's a very nice separation of survival and gauging prognosis between those, that have high and low uptake. We then wanted to take, again, this is all done, in the PET imaging center and the computer lab associated with that. So it's up until this point, it's most of it is imaging based. So we wanted to determine what's the underlying mechanism. So have a more mechanistic, a functional approach to what's going on, to try to understand what's underlying all these observations that we're seeing on the imaging side. So I told you earlier that each tumor is collected, and we fix and generate blocks and sections, so we can do immunohistochemistry. Later on, I'll show you some of the in vitro work and so on. But you can see that, again, the initial and rate limiting enzymes of the kynurenine pathway are differentially expressed in different grades of gliomas, going from lower grade to higher grade glioblastoma. And there's a general trend of increasing expression of these enzymes with increasing grade. AHR, we'll come back to later on, has, I believe, a special, special role that, that seems to be also critical in both generation and formation and sustaining tumors in the brain. Very quickly, a couple of slides on brain metastases. These are some of the more common extracranial malignancies that will present with brain metastasis. When if a patient comes in, and here are 3 examples of MRIs and their associated tryptophan PET images, it's really impossible to know which one of these is going to be a glioblastoma, which one is going to have a lung metastasis or a breast cancer underlying, and this being their initial presentation. But interestingly, when we do the quantitative analysis on the tryptophan images, we can segregate, just like we could segregate amongst low-grade gliomas, each unique histologic type of tumor that you can differentiate based on the amino acid, the tryptophan tracer, which you cannot do based on MRI or other type of modalities. So again, becomes very interesting. So that if someone comes in with a tumor and has a profile that's consistent with the GBM, well, we don't need to spend resources and waste time and delay intervention to rule out underlying primary malignancies. So they don't need CAT scans and PET scans and so on, to look at their extracranial structures. Bone scans sometimes that we do to look at sources of possible spread to the brain. Meningiomas is a particular area of interest of mine, and you can see that in fact this is one of, I think, meningiomas don't deserve as much, not deserve, but they do deserve more more interest from the neuro-oncologic research community. I think the vast majority of interest and work amongst research groups is, it's, yes, rightfully focused on glioblastoma. It's a devastating disease, but meningiomas are equally, equally nasty. And in fact, they're the most common type of primary CNS tumor. And you can see that, the patients that have these pathologies by no means have normal survival and good prognosis often. So there's clearly a need to develop better tools for managing these patients. So, as our experience, and we said, okay, here, this is great. We're, all initial questions that we wanted to answer, it seems that we're getting these meaningful results, and so let's expand. And I remember the first couple of patients, meningiomas that we scanned, more for fun and out of curiosity. Meningiomas, just like low-grade gliomas, are very slow growing. They can be present for decades, 10, 20, 30, 40 years. For example, this tumor didn't grow over 2 months. It's probably, 20, 30 years. And interestingly, when we looked at these very slow growing tumors, in fact, they had some of the highest uptake values amongst all tumors that we saw, higher than glioblastoma in a lot of cases. So what's going on? So again, bringing the tissue back, so from an imaging point of view, we could differentiate, just like the gliomas, between low grades and high grades. So, in keeping with, with the underlying proliferation, the higher grade histology, but you could also, also differentiate, with the upregulation or overexpression of the underlying enzymes and metabolites of the kynurenine pathway. So there's a common theme that's building. So we started off with serotonin and psychiatric disorders. We moved on to epileptic cortical tumors. Then we moved on to non-tumorous epileptic lesions like cortical dysplasia, and then the epileptic low-grade lesions like DNETs, and then other low-grade tumors, then high-grade gliomas, metastases, meningiomas, and they all have, if I had a composite image, it would mimic more or less this, that the higher the grade, the increased expression of these enzymes and kynurenins, or the metabolites, and it's across all grades in an increasing manner and across all tumor types. And in fact, whereas the first decade or so in the field, most groups focused on IDO, and specifically IDO1. But then about 5, 6 years ago, we noticed that rather than IDO, it was really TDO that was really the main initial, the main player in terms of overexpression. So at this point, early clinical trials, and even now, I looked at ongoing clinical trials using IDO, using inhibitors of the kynurenine pathway. They're still focused on IDO. And based on our work, at least from the neuro-oncology side, they're predicted to fail just because they're relatively low expression, as you can see. And really what we need is more advancement and development of agents that are going to specifically target the TDO that need to come on, on clinical trials. And this is just quantitation of the histochemistry, and as I mentioned, increasing expression, and TDO seems to be a big player. Again, in addition to the downstream metabolites, which we know are deleterious to neurological function, and of course the transporter that gets the tryptophan into the tumor cells. So now the natural question is, okay, well, we have our imaging modality that shows as a surrogate of increased upregulation of this pathway, and we know that there are selective inhibitors of various enzymes, both upstream and downstream of of the kynurenine pathway. So are they at all effective? So again, just a quick recap of the pathway, the different enzymes that are involved, and this is just a subset. These are some of the inhibitors that we used, and at this point, we can double, triple the list of selective. And there's development of pan inhibitors, so selective, non-selective inhibitors that can target specific enzymes of the pathway. And what so we saw that inhibitors of IDO1, IDO2, this was not surprising given our expression data, but we were disappointed that TDO did not result in cell cell loss in terms of either gliomas, meningiomas, even our lung metastasis cell lines did not respond to these IDO-TDO inhibitors. So that one possibility was that we know that there's a close link with the immune system, and of course, in an in vitro system, there are no circulating lymphocytes, or it's a non. You have to negate the immune system activation in these in vitro models. So, is that a possible explanation for why we did not see, observe this positive effectiveness? At the same time, as we looked at the enzymes and metabolites, and I mentioned this earlier, AHR was one of the things that stood out. So AHR, just like the other enzymes and kynurenins, is overexpressed in these tumors. So both, from the cellular, so this is cytosolic as well as nuclear. And remember, AHR is translocated into the nucleus. That's really the effective, when it gets activated and results in overexpression of other subsequent genes. The overexpression of activated AHR in these tumor cells was an area that was worthy of pursuing further. And again, to recap that AHR is relevant in the kynurenine pathway in a couple of ways. Kynurenine, as we mentioned at the very beginning, is the endogenous ligand of AHR, and AHR in turn results in upregulation and overexpression of IDO1 and IDO2. So it forms this feedback, autocrine loop mechanism. And we know that AHR overexpression and activation results in a pro-oncogenic environment, and in terms of gene expression. So that in theory, whereas inhibition of IDO1, IDO2, TDO should have stopped the conversion of tryptophan into kynurenine. And in theory, if there's no kynurenine, AHR can translocate into the nucleus. That's one side, but the reality is that there's likely many more additional unknown endogenous ligands of AHR that continue to activate it, thereby bypassing this, initial or primary or, this upstream path for AHR activation. So then we started focusing attention on this component of the pathway. A quick review of AHR. So AHR is a ligand-activated nuclear transcription factor. It forms a heterodimer, and when it's associated with its nuclear translocator and gets into the, binds to the DRE region of the gene, and activates and increases gene expression selectively. And we know that activity of AHR is very important in maintaining normal cellular homeostasis. It's a very important aspect of anti-inflammatory activity in normal cells. Unfortunately, it is also known to be involved in various pathologies. And as we discussed, it has significant tumor promoting activity based on its mechanism of action. Thankfully, just like for other, for the other enzymes of the pathway, kynurenine pathway, you can target AHR. So there are specific drugs that can selectively or non-selectively antagonize AHR activity. And this is, just briefly some results of one of these antagonists that finally resulted in cytotoxicity. So you can see, compared to controls in both gliomas, meningiomas, and lung metastasis, it's the last column over here, AHR antagonism results in significant decline in cell viability of these tumors. So finally, and this is based on MTT assays, of course. So finally, we have we're kind of getting closer in terms of mechanism, and getting a bit closer in terms of therapeutic side. I mean, that's the whole purpose of a translational research program. Is it's not just for the sake of knowing, of knowing all these tidbits, it's how do we improve ultimately the lives and you know, not just quantity, but quality of life of patients. So there has to be some clinical meaningful use out of all of this work. So this is potentially an area that we can target. More work needs to be done, but it's promising. So AHR, we've seen, is overexpressed in a variety of tumors. It can have either negative or positive prognostic factors. So that's one thing that's interesting. As you, again, get deeper into the topic, we see in other extracranial pathologies that it may have, depending on which model and which circumstance you're looking at, it may actually be pro-oncogenic, or in other circumstances, it may be a tumor suppressor. So if it's a tumor suppressor, you want to increase expression, whereas if it's a pro-oncogene, then you want to suppress it and antagonize its activity. So depending on, on the specific scenario that's determined based on underlying pathology, you can use either antagonists or agonists, from a therapeutic point of view. So this can be highly tissue specific and response specific in terms of expectation. And again, we're getting closer to the, to the targeted therapies, the personalized medicines, and so on. So you can imagine that for, even individual variations, amongst patients with glioblastoma, meningiomas, and et cetera, you can see perhaps that, a patient will have high activity of AHR and you need to antagonize, whereas someone who has low expression, lower than normal, you should use an agonist instead. So you can really, fine tune. So in the last, I would say, year or two, we started looking more and more, shying away from IDO almost completely in terms of, as a viable clinical, clinical action point. If anything, IDO, I suspect that the only time it's going to show meaningful, results in clinical trial settings is in the setting of either combination with TDO, AHR, or other inhibitors, or a pan inhibitor of IDO, TDO, et cetera. So those specific molecules are in development right now and haven't made it to clinical trials. So what we've been focusing on the last couple of years is investigating the role of AHR in GBM, but at a more functional and molecular genomic level. We, again, using our patient-derived glioblastoma lines rather than established lines, and again, using a range of different methodologies. And unfortunately, and this, the role of AHR in CNS tumors, GBM specifically, was, in our opinion, our humble opinion, was greatly hindered by this Nature paper from, it's now been almost 10 years now. And this has been viewed as gospel, that, so this, and this group is we actually collaborate, but we disagree strongly on this point, is that they've noted that AHR, and they were the first to determine that AHR actually seems to be protective and dissuade cells from invading and growing in GBM. And over the last certainly 4, 5, 6 years, all of our studies in various tumor types have shown exact opposite. And it's been, every year, and this is probably one of our latest papers that are kind of gnawing and chipping away at this, what's now gospel, that HR is, is good, in terms of GBM. So what, and
Dr. Mittal,
yes.
I'm wondering whether I can just interrupt real briefly. I know several of our students have to leave to go to a different Zoom meeting in about 5 minutes. And we've had a few questions come in. So either we could take a few questions now, or I could let you wrap up.
I think these, I think these are the last 2 or 3 slides. So I can just very quickly go through, and then if you permit.
Great. Sounds good.
So this, I think the students have gone through the paper already, so there's no point in dwelling, but suffice it to say that as we knock down AHR, using various, oligonucleotides, that there was increased invasion, there was increased proliferation and invasion. So in effect, the in our hands, AHR is acting like a tumor suppressor rather than a pro-oncogenic agent, as the Nature paper alluded to. So we want to really expand in more in vitro work using the different antagonists and agonists, as I mentioned, expand, and we've already begun the in vivo work in our PDX models. And just very briefly, PDX that can be either subcutaneous or intracranial models. These are patients, tumors that we can grow subcutaneously within the brain. You can do the human patients, PET imaging, implant the tumor in the mouse flank, and you can see correlate the parameter of tryptophan imaging in the mouse, implant intracranially and see the tumor uptake of tryptophan in the brain, let it grow, see increased uptake after a few days. Here, we've talked about AMT as a C11, so a short half-life, and that's one of the main limitations of AMT is that we really need to transition to an F18-based compound, and we've begun the preclinical studies, and it actually shows that this particular F18-based tryptophan molecule seems to have better signal-to-noise ratio and uptake in the tumor compared to AMT. And overall, again, very quickly, amino acid labeled tracers are actively transported into tumor cells. It provides superior sensitivity, can detect viable tissue, and certainly better than FDG, and nicely complements MRIs. We can use our animal models, the PDX models, to use to transfer and augment our knowledge of the imaging parameters. I hope I know, and I apologize for going way over time, but I hope that I've given you a good glimpse of why this pathway, and not just for brain tumors, but for, again, it's kind of crazy how this is a critical pathway involved in all sorts of pathologies, but that we can really harness for treatment, of CNS tumors. And AHR is really, I think, an area that we're going to explore quite a bit in the future. So more experiments centered on AHR, in addition to the other enzymes and metabolites, work on developing and bringing fluoroethyl tryptophan here at Tech. We'll be applying for an IND. So again, without the IND, we can't use the F18 compound in patients. So we want to, again, develop personalized therapies, make more effective and novel therapies, and expand further to include non-oncologic, non-epilepsy-related neurological disorders. Again, stroke, traumatic brain injury, Parkinson's, Huntington's, Alzheimer's, psychiatric conditions. The list goes on. There's significant potential for this pathway, and targeting it, both from a molecular, small molecule approach as well as an immunotherapy type of angle. And just like most things, combination treatments is probably going to be the answer rather than individual magic bullets. A lot of people, as you can imagine, behind the scenes worked and facilitated all the work. And with that, I will stop.
Mm-hmm. Thank you very much. It's clearly a very rich area of research, and it's exciting to have such an expert here to share that with us. We did have a few questions in the chat, but I think given the fact that I know a big chunk of our students have something to transition to at 2:30, I'm going to go ahead and let those students follow up with you on their own, and then just reiterate our thanks to you for participating and giving us that overview. Thank you very much.
My apologies for running way overboard here.
No, excellent talk. Thank you very much. Students, medical students, we will see you over in the other Zoom room for oral presentations, and thank you everybody for joining us. Appreciate it.